eviction. There's got to be a bacteria that's involved in rosacea. Why else do these tetracycline drugs work so well? The truth is we're not using antibiotics for their antibiotic features. We're using them for their non-antibiotic features. We know that the tetracycline family of drugs are great as anti-inflammatory agents. They decrease oxidative stress. They improve dermal destruction. They also help abnormal vasculature, all the things that we want for a rosacea patient. Looking at topical minocycline, this was a foam formulation that was formulated and approved for moderate to severe rosacea patients who had papules and pustules. And we see that about 50% of these patients using this medication once a day for 12 weeks got to clear or almost clear. Here's an example of a patient who had moderate disease who went to a clear. Even the second patient who had moderate disease who wasn't a treatment success certainly had a clinically relevant improvement going from a moderate to a mild. But one of the important questions in terms of safety that I have to ask about a topical minocycline that applies high doses of minocycline directly on the skin is, do we see minocycline-induced hyperpigmentation? And the answer is, in the clinical trials, we did not see that. There was one case of post-inflammatory hyperpigmentation, but we didn't see any minocycline-induced hyperpigmentation. We have a new oral minocycline that was recently FDA approved in the United States, also for the papules and pustules of the rosacea. It's interesting, in the phase 2 studies, we looked at 2 different concentrations, 40 milligrams extended release, 20 milligrams extended release minocycline, and we compared it not only to the placebo, but also to submicrobial dose doxycycline, which has been proven to be effective in rosacea. And when we look at the data, we see that the 40 milligram extended release gives us the highest efficacy to date in terms of getting these rosacea patients to clear or almost clear, about 2/3 of the patients. But the important question here is, this is a lower dose minocycline, but is it antimicrobial? Because if it is, why not just use full dose minocycline? Well, we do have some studies that looked at the effect on normal flora, and in this study of 60 healthy patients, we didn't see an effect on healthy flora, and that was true on the skin, the stool, and the vaginal area. And we also didn't see the development of bacterial resistance. This is a short-term study. We'll have to see more over time, but this is good news. This drug also completed 2 phase 3 clinical trials, and the data held true. We still saw up to almost 2/3 of patients clear or almost clear, again, highly statistically significant improvement compared to the submicrobial dose doxycycline as well as placebo. What about the side effect profile with this lower dose minocycline? Overall, this drug was very well tolerated, and adverse events were generally mild or moderate. I talked about the fact that we have an encapsulated benzoyl peroxide that was approved in the United States for the treatment of rosacea. And you might say to me, I'm no fool. I could go to the pharmacy and buy benzoyl peroxide, and it's not very expensive at all. But there's a problem. You know what happens if you put conventional benzoyl peroxide on a patient who has rosacea? They are not happy with you. And that's because the irritation profile is very difficult. The silica encapsulated benzoyl peroxide wraps around the benzoyl peroxide particles and allows for a very slow and deliberate release of the benzoyl peroxide. In doing this, we really have a very minimal exposure of the skin to the benzoyl peroxide, and we stay below that irritation threshold, whereas with conventional benzoyl peroxide, we get kind of a dump of medication, causes a lot of stinging and burning. Patients might use it once, but they won't use it again. And we found that in terms of efficacy, again, up to 50% of patients using this medication once a day for 12 weeks got to clear or almost clear. What I found really interesting was the tolerability profile. As compared with conventional benzoyl peroxide, when we put this on, the skin actually improved in the stinging and burning. It's very rare that you see the irritation lines go down with the beginning of use of a medication. Ivermectin for rosacea has been around for quite a while at this point. We know that ivermectin kills Demodex, but also has very potent anti-inflammatory properties. This drug was studied as monotherapy, and we found that about 40% of patients got to clear or almost clear. And this picture was shown already, and I wanted to make exactly the same point. You see the papules went away, but the patient still has some background erythema. So we treat the perilesional erythema, but not the background erythema. And we see that again with the second patient. We see the perilesional erythema goes away with the papules, but we still have that persistent background erythema. This drug was studied head-to-head in Europe compared with metronidazole cream BID, treated for 16 weeks. Then patients who got to clear, almost clear, went off drug until they got mild disease or worse. And we found that topical ivermectin is statistically superior to metronidazole, and that difference occurred as early as 6 weeks, and the separation continued through the 16 weeks. In terms of the side effect profile, these drugs were both actually quite well tolerated. But patients, when they got to clear, almost clear, could stop their medication, and we waited to see how long it took for their disease to come back. Does it really make much of a difference if we get the rosacea patient completely clear versus almost clear? Does it really matter? And the answer is yes, it actually matters quite a bit. If you can get a patient completely clear of their papules and pustules and take them off drug, they have at least a 5-month better durability of their remission than if they got to almost clear skin. So really aim for clear of the papules and the pustules. Now this issue came up. What about patients who have background erythema and papules and pustules? What are we supposed to do for them? Combination therapy is really going to be important. But the question is, if you apply an alpha-adrenergic agonist to a patient who has papules and pustules, I'd say don't do it. You're going to take away the redness, and all they're going to see is the papules. It's probably a better idea to wait. Apply the ivermectin first for a little while, and then introduce the bromonidine. So this was a study that actually looked at that. They said, does it make a difference if we start bromonidine and ivermectin at the same time, using ivermectin at night, bromonidine in the morning, continue this over the course of 12 weeks, or should we start the ivermectin first and then introduce the bromonidine? Does it really matter? And then they also looked at just the vehicles. And I was really surprised by this. I love when science kind of tells me I'm doing something that's not right. So when we look at how many patients got completely clear of their papules and the pustules, it turns out the patients who started the medication at the same time had a much better improvement in their papules and pustules in terms of getting to completely clear skin than if they started with the ivermectin and waited a little bit with the bromonidine. The other thing we found was when you use these two drugs together, the bromonidine is much better tolerated, probably due to the anti-inflammatory effects of the ivermectin. So why is this? Why do we see such a nice result when we use these drugs together? This is a nice animal study that looks at the anti-inflammatory properties of ivermectin and bromonidine compared to either vehicle or mid-potency steroid, betamethasone valerate. And we see the ivermectin, we see the bromonidine, but look at what happens when we use them together, almost a synergistic anti-inflammatory effect. Okay, what if you have telangiectasias? You can put cream on these all day and it's not going to make any difference. You're really going to have to use a device. And if you have a FIMA, is it inflammatory or non-inflammatory? If it's not inflammatory, you're probably going to have to use a surgical approach. What about ocular rosacea? In the United States, we have nothing that is FDA approved for the treatment of ocular rosacea. There are a number of topical and systemic treatments that work somewhat, but nothing yet approved. And this was a nice study that was published a few years ago, and just an easy use of ivermectin topically. These patients, 10 of them, had ocular surface disease as well as cutaneous rosacea. They applied the ivermectin to the face as well as the eyelids, and all of them had improvement with no side effects. I just want to conclude by talking a little bit about JAK, or is it really JAK rosacea? We know that the oral JAK inhibitors do give us a facial flare in some patients. And this was a case report of a 38-year-old gentleman who had been treated with deucravacitinib and developed this facial rash after 10 days. He did have a history of rosacea. And when you look at the facial rash, this is very severe rosacea to me. And then there was another case series that was published out of Australia where 6 patients developed what they called an acneiform eruption after starting deucravacitinib. It's not common, but it can occur. And again, these patients really look like it's rosacea to me. And the patients actually respond quite well to anti-rosacea therapy. So bottom line is, it's really an exciting time to be treating our rosacea patients. Make sure you look at them and understand all the features that each patient has. Make sure you treat each feature individually, and that generally requires some kind of combination therapy, and we can get these patients under better control. Thanks so much.
Thank you so much, Linda, for this wonderful overview. We will continue now, and we will go now into Rhinophyma, and we will have Professor Florian Anzengruber from the University in Chur in Switzerland, who's trained in Zurich, and he will give us an overview about Rhinophyma treatment. Thank you.
Thank you very much for the introduction, dear colleagues. It's a pleasure talking before you today. It's very difficult to speak after such a good speaker, so thanks a lot, Linda, for giving such a good presentation. I will talk about the management of Rhinophyma. Chur, where I'm from, it's close to Davos, close to Liechtenstein, about 1 hour away from Zurich. If you ever are at the World Economic Forum, make sure to say hi. These are my conflict of interests. You will see they are not associated with this topic today. So when you have a patient like this, it will be quite easy for you in a clinical setting because you see that every now and then. But when you have a patient like this, you might need to look a little closer because that is also a phyma, but it is located on the chin. We call it gnatophyma. And the same can happen when you have it, or when your patient has it on the ears. Yeah, we call it autophyma. And it's not that easy to treat, and it often gets misdiagnosed. But what is that? Well, this might help you. Is it gigantic rhinophyma? That patient apparently waited too long. It is also an autophyma. The patient has rosacea, and it might also be a gnatophyma. So when do we treat our patients? Here are some facts and figures. Rhinophyma it's a hypertrophy of the sebaceous glands and the connective tissue. We have chronic inflammation. Most of the times, the nose is involved, but not always. We have a clear male predominance with 20:1, a thickened skin, prominent pores, and irregular surface contour. There is a cosmetic part to it, but in some patients, there's also a functional impairment. And the pathogenesis is multifactorial. So when do we treat our patients? It can be from aesthetic disfigurement to functional obstruction, psychosocial burden, or to exclude malignancy. In general, tell your patients the following thing. Sunscreen. Here it says SPF 30, but basically I always say 50. Have hats. You don't go outside in the mountains or when you're at the sea around noon. Try to avoid triggers, heat exposure, stress, extreme temperatures, hot drinks, spicy food, or alcohol. And now some are going to say, why alcohol? I think it was proven that there's no association between rhinophyma and alcohol. So about 10 years ago, when we wrote the Swiss guideline, we looked at so many references. We found so many mutations in literatures where somebody read the primary study wrong, cited it wrong, and it continued like this. And back then we looked at the evidence for rhinophyma and alcohol, and we did not see a clear evidence that this was associated. A couple of years later, there was this very nice study. It's a French Luxembourg study. And what they did, they took 52 cases, 156 controls, with rosacea and rhinophyma, and they looked at the drinking habits, and they found that the more you drink, the more likely you are to have rhinophyma. But not only that, they also discovered that if you have a family history of rhinophyma, you have an odds ratio of 160 to also get a rhinophyma. And also diabetes had an odds ratio of 6. So how are we going to treat it? Well, basically, there are two possibilities. One is the medical treatment and one is the physical treatment. We first look on the severity of the patient, and then we decide, do we want to start with a medical treatment or do we want to start with a physical treatment? I think we all agree that a patient with number one, we would treat differently than the patient on the right, number 6. So in some cases, you have really severe cases. This is, you might know her. She's a colleague, a dermatologist from America, Sandra Lee. She goes under the name Dr. Pimple Popper, and she has a YouTube channel, or probably several channels, and she had one patient with a huge rhinophyma. And of course, this patient you would treat with surgery and not with medical treatments. Some, they like to evaluate the severity with a score. We don't at my department. We just look, is it rather mild or is it rather severe? And then we start. So what is the evidence for medical treatment? Well, not very good. We have no clinical trials. We have no randomized control trials. We only have case reports and case series. But I will show you some quite impressive case reports. So this is a case report of a group in Poland, with a very good reputation, a study group, and they had a 31-year-old Caucasian woman, 6 months of history of rosacea fulminans and rhinophyma. She had a cauliflower-like deformity of the lower 2/3 of the nose, and before admission, she was treated with topical antibiotic ointments. She also had a vision impairment and needed to undergo surgery for that. So that group treated that patient with 40 milligrams of isotretinoin, which is, for my taste, quite high. We usually go a lot lower, but it worked for that group, and they did it for 4 months. Then they increased to 50 milligrams for 3 months, and then they reduced it to 30 milligrams for 6 months. As I said, the patient was also undergoing ophthalmologic surgery because she had an involvement of rosacea of the eye. And this is a result that I would have not believed if it wasn't published by a reputable science group. And I was actually quite amazed. So I give you a second case. This is a second case of a German group, and they had a 62-year-old man with rhinophyma. And from what I understand in the article, they gave him the options, what he wanted to choose. They said, either we're going to do surgery or a laser on you, or we're going to treat you conservatively. And the patient opted for the medical therapy, and he did a therapy for 2-3 years. So they had a different regimen. They used 20 milligrams every 3 days. And after 3 months, they already realized that there was a marked reduction of sebaceous gland activity, inflammatory activity, and nasal volume. And they also started with topical ivermectin, and the cream was then discontinued. So after 12 months of treatment, they saw further narrowing of the nose, normalization of seborrhea, flattening of previously enlarged sebaceous glands. And after 24 months, they went to 20 milligrams every 4 days. The patient didn't have any side effects, and that was the result. So it was not as extraordinary as in the first case presentation, but it's still, I think, a quite good result. You will find in the literature that some dermatologists and maybe plastic surgeons, they use it before or after surgical treatment, before to stabilize the disease and afterwards to reduce the risk of relapse. So what about antibiotics? Well, I went to PubMed and I put in rhinophyma and antibiotics, and I didn't get anything. I only got reviews. Yeah. I didn't get any really solid scientific evidence. So then I went to rhinophyma and tetracycline, didn't get anything either. Then I went to rhinophyma and doxycycline, didn't get anything. So I used my favorite tool from Sam Altman, ChatGPT. And I asked, is there any antibiotic treatment? Is there any evidence, any scientific evidence? And it says, yes, there's scientific evidence. And quoted a very good Danish scientific group. And said they looked at doxycycline and isotretinoin. And I looked at the paper. But when I looked at the paper, I realized, no, they didn't. Yeah, they actually looked at cold plate technique versus CO2 laser. So it's just another lesson, it's a hallucination. I think, was it your group? No, okay. But it was a Danish group, and it was just an hallucination. So always be very, very careful and tell your patients to be careful when they use ChatGPT. So basically my recommendation, topicals, well, they're not going to hurt, but they're probably not going to do a lot. Not in rhinophyma. Oral isotretinoin, yes, it might work in the early stages. It might not be or will not be effective in fibrotic rhinophyma. It has its place pre-surgically, and some people, they use it post-surgically. Don't use it during surgery. Don't use it during laser because of the photosensibility. Antibiotics, I didn't see anything. Maybe you get down to chronic inflammation and it's a little less red, but you're not going to stop the rhinophyma. All right, so let's go to the physical surgery, to physical therapies. Surgery, lasers, radio frequency. So I looked at that paper and I really loved what they wrote. They said, to the best of our knowledge, there are no randomized prospective controlled studies for any treatment, which makes it difficult to recommend a single treatment over another. And I think they got it to the point. Yeah. Basically, you can divide the physical treatments: mechanical destruction, directed electrical energy or radio frequency, or directed laser energy. So basically, you can do it with the plate. This is how I was told as a resident to do it. There's dermabrasion. I've never done it personally, but I know some dermatologists, they're big fans of it, so that is a possibility. CO2 laser, this is, I think, what most of the dermatologists are doing right now. And especially when you have a severe rhinophyma, some use a radio frequency via loop electrode, and they try to get it all flattened out. But the best treatment is always the treatment that you feel most comfortable with. Described, there's cryotherapy and photodynamic therapy. If it works for you, tell me after the presentation. I have my doubts that it will be sufficiently effective. So I give you a couple of reviews, basically comparing laser, CO2, and erbium. Basically, in a summary, both work very, very well. I thought that was a very good review. They took the different, mostly retrospective case series or case studies. You see from one person to, where is it? 1 person to 124 people in the study, and they also look at the settings that they used. However, I personally, I always take a wooden spatula. I go with the CO2 laser. I see how aggressive it goes, how big the size is, and then I just adapt it depending on the rhinophyma of the patient. And when you look that there are complications, hyperpigmentation, 4 people, hypertrophic scars, 1 person, but if you look that there are 124 patients treated, this is nothing. Yeah? 8 patients having side effects out of 124, those are very good results. And you can also see that the results good to excellent, 118 people compared to 6 which were poor. And I have to be honest, all the people, all the patients that I've seen after rhinophyma, they're so happy, and even if it doesn't look the way it was before, they're so happy because it looks just so much better than before. And also for the erbium, they had less side effects, so basically both are very effective, but with the erbium having a little less side effects. There's a study looking at isotretinoin combining with CO2. Basically, you see it on the treatment outcome. This is a small study, all good. Maybe the person was just very good doing lasers. So right now, I wanted to show you a video of us doing surgery with a patient, but the legal department in our hospital did not want me to show the pictures, so I found a very good YouTube video, and you will very much enjoy it. So for those people who have never done it, this is a very good one. Okay, so you have 3 nerves that you want, where you want to do a nerve block. We also do local anesthesia additionally. It might not always be necessary, but sometimes we just feel better if we do it. You have the dorsal nasal nerve, you have the infratrochlear nerve, you have the infraorbital nerve. And basically, here in this picture, what they do a blockade of the nose, they blockade the infraorbital nerve. We always do it from within the mouth. I cannot tell you which one is better because I've never done it the way they've done it. I just have the experience that if you do it from within the mouth, it works quite well. Then if you look at the dorsal nasal nerve, you just go 1 centimeter from the midline, and you just change the direction of the needle a couple of times. And then the sensory nerve branches from the nasopalatine nerve are blocked at the base of the columella, and then you also go a little bit superiorly. So this is the video.
Nerve block to the nose. The sensory innervation to the nose is supplied by the dorsal nasal nerve, the infratrochlear nerve, and the infraorbital nerve. The dorsal nasal nerve is located proximal to the caudal end of the nasal bones. It is found 10 mm lateral to the midline of the nose. Blockade of the nose proceeds systematically. First, block the infraorbital nerves on both sides to anesthetize the lateral parts of the nasal side walls and the EADV. Next, proceed to block the dorsal nasal nerves. Insert the needle proximal to the caudal end of the nasal bone, 10 mm lateral to the midline of the nose. Enter perpendicular to the skin and deposit 0.25 ml of anesthetic solution. Then, partially withdraw the needle and redirect it inferiorly to deposit another 0.25 ml of anesthetic. Next, withdraw and redirect the needle superiorly and advance toward the root of the nose along its lateral wall. Deposit anesthesia slowly as the needle is advanced. Sensory nerve branches from the nasopalatine nerve are blocked at the base of the columella. Finally, infiltration of the distal half of the nose is performed, starting from the columella for added anesthetic and vasoconstrictive effect.
To be honest, I also don't do it as nicely as they do it in the video. And then there's a short video of CO2 laser for those who don't do it regularly. So the advantage of using a CO2 laser in that case is you have less bleeding, but it takes a lot longer. There are some... I've looked at several videos and I saw several teams do it a little different. Most use the scalpel, the blade, in very big rhinophyma, and do then to do to do the close-up with CO2. Some, they use a ring curette to get the skin very smooth. And some even use some sandpaper to get the smooth skin. So overall, you always do secondary intention healing. It usually is a very, very good aesthetical result. Don't do primary closures, flaps. Sometimes we see from especially from plastic surgeons, they want to close it. It's not a good idea. After the surgery, tell the patient to use antiseptic soap, mild antiseptic soap. Try that it's always moisture. We like to use topical antiseptics. Always photoprotection, this goes without saying. No manipulation, medication adherence. This is, we always do an HSV prophylaxis of valaciclovir 500 milligrams twice daily. We start 2 days before and do it over a course from 7 days. However, if you look in the literature, some do it for 14 days, some do it, don't do it at all, some only do it if the person has recurrent herpes. We don't do an antibiotic prophylaxis, but I always like to give the patient analgesics. I personally, I like paracetamol because I'm a little bit afraid of the bleeding. Avoid topical irritants and just closely monitor the patient. We monitor the patient the day after the surgery, 7 days after, and 3 weeks after. Thank you.
Thank you so much, Professor Angruber, for this wonderful overview on this very much neglected subject. I think we all learned a lot. So now we go to our last talk, and it's a privilege and honor to introduce Professor Anna Dinardo. Who's the director of the Research Institute in Rome, and also a full professor at the University of San Diego in California. So thank you so much for coming. And Anna will talk about rosacea and new treatments. Thank you.
Hi everybody, thank you for staying so late and to listen to me. And I'm going to challenge you a little bit, because you heard about pathophysiology and how rosacea is made and all the possible treatment. And now I'm trying to pull everything together. I have no conflict of interest. So the key point of this presentation will be that we have a different phenotype, that base classification. There is a pathophysiology center management, you already heard about that. Patient-centered management, you have to look at your patients and decide what the patient needs. Treatment optimization, and the pipeline innovation. You already heard about the new rosacea classification that is mostly phenotype-based system. So you have major features: transient erythema, inflammatory papules, pustules, telangiectasia, macular, ocular manifestation. They all qualify for giving you the diagnosis. And then some secondary features that are supportive but not diagnostic. And you have seen this, so the facial erythema covers all the possible variables, the same telangiectasia, and then you have inflammatory lesion that covers some of them, but not the ETR, and the edematous changes that can cover all of them, including the ocular symptom that frequently starts actually years before the others, but nobody really pays attention to it. The treatment goal setting is very important. So what we want from our treatment? We need to achieve clear or almost clear skin, reduction in the severity of the features, possibly reduction on the frequency of the flares, an improvement in the patient-reported features, achieving the patient satisfaction, that is very important, so the patient comes back to you, and the reduction in impact of rosacea on the patient. So why is it so difficult to treat rosacea? Because rosacea doesn't have one single reason to be there. He has at least 4 components: external triggers, genetic predisposition, immune dysregulation, and neuro and vascular dysregulation. So we need to address each of them to be able to treat the rosacea. First of all, the outside, the external trigger. The external trigger can be very complicated. We have skin barrier that might be altered, so we have an increased transepidermal water loss, that actually brings to an altered pH that, again, brings to inflammations, pathogenic bacteria that likes the alkaline skin better than the acidic skin, the presence of different kinds of bacteria that are not present on the physiological skin, like the Bacillus oleronius, or other bacteria that are present on the normal skin but are much more abundant in rosacea. And those, for example, are the Staphylococcus epidermidis, and inside the follicles, the Demodex follicularum. So, to address this first group of external trigger, we have topical treatment. First of all, you have to tell your patients not to expose to their skin to the UV, use skin barrier protection, using UV protection. But some are already been approved by the Food and Drug Organization. And the topical are the topical metronidazole that can come in two formulations, 0.75 in gel or 0.1 in cream. That is being proven to improve the skin by 48%. Azelaic acid that comes in two formulations as well at 15%, with an improvement of 57%. Then we have topical ivermectin at 1% with an improvement of 67%. Minocycline foam that clears 50%, but versus placebo of 40%, and encapsulated benzoyl peroxide at 5% that has right now the most attention with the IgA of 50%. This is how the BPO 5% that you already heard in the previous presentation works. It works pretty well, as you can see in two different studies, but why it works well? It works well because it reestablishes the normal microbiome on the skin, like you can see in this second part of the presentations. In fact, interesting enough, on the skin of rosacea, there is too much Staphylococcus epidermis. And applying the BPO at 5%, that on other kind of skin will be just an irritant, actually regulates the quantity of the bacteria present and reduces the quantity of Staphylococcus epidermidis. Skin barrier. Skin barrier is very important. You heard about skin barrier mostly for atopic dermatitis, but actually there are recent studies that are re-evaluating the skin barrier also in rosacea. If you are more interested in seeing a recent study, you can go and see the poster that is being presented at this meeting, that is from my lab right now, in which you can see that ceramides are decreased in rosacea. They are decreased in rosacea in a different way that they are decreased in atopic dermatitis, but they're still increased. So why we don't have an atopic dermatitis instead of rosacea? And actually, studying for this presentation, I found this study from Dr. Matt Gazzi that I found almost genius, in which you can see that if you have a skin that has a lot of sebaceous gland, you have a Th17 environment. So with the skin barrier altered, plus the sebaceous gland present, you switch to a Th1 to Th17 inflammation. But it's like in atopic dermatitis, that is usually in area that is not rich in glands, but in also atopic dermatitis has a reduction in sebaceous gland in general, then the alteration of the skin barrier brings to a Th2 IL-4 kind of environment. And so instead of having atopic dermatitis, with the rich glands, you have rosacea. And Th1, Th17 brings us to another study that is actually done by Professor Steinhoff here present, in which he proved that the presence of the Th into the skin of rosacea is a Th1, Th17. So this brings us to the new investigational treatment. There is right now recorded pilot study on secukinumab, anti-IL-17 monoclonal antibody that is an open label and has been released recently, the study, and we will see the publication very soon. Immune dysregulation brings us to other possibility of investigational treatment. Dapsone is one of those. It can be used at topical 5% or 75% in gel. It is used off-label. Its main activities is on neutrophils. So rosacea presents neutrophils. Dapsone might make it better. There is only there's not been a clinical trial, but just off-label published study. The same for topical calcineurin that actually works blocking the T cells activations, and as we can saw before, there is Th1 and Th17. On this one too, there's been just a single publication. It can be used as an anti-inflammatory without having the side effect of the topical steroid. We talk about the bacteria, Demodex, and the overexpression of the TLR2 in the surface of the skin that brings to an increase of kallikrein-5, and kallikrein-5 activate LL37 antimicrobial peptides. The activation of LL37 antimicrobial peptides brings to more recruitment of neutrophils, macrophages, mast cells into the skin, but also to the activation of NF-κB, JAK-STAT, NLP3, and so angiogenesis, inflammation, and increased cell death. What can we do about that? Our first line of defense for many years has been macrolides, anti-inflammatory properties. They come from tetracycline. As you can see, there are 4 rings here, tetra, that has a lot of good activity. It decreases granulomatous inflammations, it decreases cytokines, it decreases the cellular migration, the ROS, decreases angiogenesis, decreases the metalloprotease. So what we use for those are 2 currently approved oral doxycycline at 40 microgram that has a clear of 26% versus placebo 15%, and minocycline hydrochloride extended release, so they're both extended release with a clear of 65% versus 31%. So they're both effective. Minocycline, it seems in the later study to be more effective, but the problem with all the studies, not just this one, on rosacea is that placebo effect is always high. Why not to use the full dose of doxycycline? Because doxycycline and tetracycline in general becomes antimicrobial at a threshold over 50 milligrams. So we have to use extended release that keep always the concentration below the threshold of antimicrobial. At this level, we have only the anti-inflammatory activity, but not the antibacterial activity. Of course, the last coming to investigation also for rosacea are the JAK-TYK2. There are many that are right now registered in studies. We have the upadacitinib, the atrocinib, and other that are under investigation. Some have been enrolled directly at the NIH, others are still not registered but are in trials. And then we have also the TYK2 inhibitor that is registered, and we hope to have the results released soon. Inflammatory phenotype, there are also other things in the pipeline that has been tried right now. One is the gel that is able to inhibit the TLR2 and the G protein couple receptor signaling that has been registered. We have ROS inhibitors. Of these 2, still we don't know the final results of the study, while of the anti-PDE4 inhibitors, at least for apremilast, we have the results, and it's actually very promising results. We have a significant improvement in physician rate erythema measures. There are others that are still in the pipelines, and we will have the results hopefully soon. After that, we have to go to the vascular area. So, as we said, keratinocytes can release cytokines, mast cells can release cytokines, the nervous system can release cytokines, and all those contributes to the vasodilation through the release of substance P and CGRP. This brings us to the vascular dysregulation. Right now we have 2 approved and 1 that is used out of label. The brimonidine, like we saw before, is a sympathetic nervous reduced erythema through the alpha-2 adrenergic agonist. Oxymetaboline works in a slightly different way. They both reduce erythema. And then we have timolol, used off label, that seems to have had some good publication. In the pipeline, erythema and neurogenic components, we have trametinib topical MEK inhibitor that is has a good safety short-term topical. Still, we don't have a definitive efficacy advantage over the vehicle in a small split phase 1 right now, but it's a way to go. And then we have the topical RIFAM VEGF2 inhibitor with small changes, so right now without clear advantages, and also an anti-TRPV1 inhibitors. The data on that has not been posted yet. Of all these new in the pipeline, one that has been released and we'll probably see soon is the erenumab anti-CPRG monoclonal antibody. It comes from the idea that rosacea is frequently associated with migraines, and the rosacea patient has increased level of CGRP. So it's an anti-calcitonin gene-related peptide receptors. In non-randomized clinical trials, has been used for moderate to severe erythema. Has been proven to decrease the numbers of flushing of -7 days, and also the days of severe erythema by 8 days. So it seems to be very promising. Last but not least, my favorite cells, because I studied those for years, are the mast cells. They have receptors like the MRGX receptor, and they have also other receptors that are very important to be the mediator between the nervous systems and the skin. They release mediator that can attract neutrophils. They can release mediator that also induce erythema and swelling. So blocking mast cells that are so important in the amplification mostly of the inflammation in rosacea is pretty important, and there are been few small studies, some are still going on, of this: the cromolyn, hydroxychloroquine, artemisinin, botulin toxin, the GLUT2 receptor that has been published very recent by Dr. Kaplan 2 years ago in Nature, and the TRPV1 inhibitors. We hope to have this study released soon too. So, sorry, this is a kind of summary of all the information we went through. We have the external trigger. You have only to do educations, emotions, food and drinks, weather, alcohol. But then we have all the drugs that I told you before that are going to address mostly the skin. Genetic predisposition, more study, but right now we cannot do anything about it. The immune dysregulation, the catalyzing pathway inactivation, the innate immunity, the adaptive immunity with the Th1 skewed. We saw everything already on the market and what is coming up. And then the neuro dysregulation with brimonidine, oxididine, the neurotransmitter, and all the beta blocker and botulin toxin and other studies that are coming up. So with this, a wide range of mechanisms that are coming in the pipeline, more than one, and unfortunately it's because it's a disease of many components, or maybe we are still ignorant and we don't know the original component of it, so we're still studying it. There is a diversity of approaching that defines how we are still looking for panacea for this disease, but there are emerging evidence that suggests that rosacea may represent a spectrum of endotype. It also has a systemic component that extends beyond the skin, and this is the one, for example, the migraine. So many drugs that have been used for other diseases are now being tried for rosacea. And while there are several FDA-approved treatments exist, there is still an unmet need to remain, particularly for therapy that can modify persistent erythema. A lot of things are moving. We went through all the pipelines. I hope this has been useful, at least for the near future, of all the drugs that you will see coming to the market. And with this, I just take questions. Thank you so much, and thank you again for being here.
Thank you so much, Anna, for this excellent summary of the new treatments. Very exciting. So all speakers were very disciplined, so we have time for a couple of questions. So please use the microphones here at the front. We also have some questions from the audience here. Maybe you also want to read the first one.
How the 40 milligram ER minocycline compared to monocycline 50 milligram in treatment of rosacea?
Maybe Linda, you want to?
In terms of efficacy, there's no head-to-head trials. What we really want to do is, what we just heard, is keep the antibiotic level below the level of bacterial killing. So we want it to be anti-inflammatory and not antibiotic. And that way we don't have the potential for, or minimize the potential for the development of resistance. So it's likely that the 50 milligram is going to be antibiotic and not necessarily just anti-inflammatory. So that's one of the main issues.
Thank you. The second question referred to Professor Anzengruber about the rhinophyma, and Charles says, I quite often do ablative and or non-ablative laser treatments during low-dose isotretinoin. I haven't seen the rumored side effects yet. Can you comment on that?
So there are two options right now. So one thing is that we are just too scared and and not rightly so, scared that isotretinoin could have a negative impact on laser. Well, the second option is that the colleague is just very good. This is my answer. But we personally, we don't do it because I'm just too afraid. But I think that if there are more people who do laser under isotretinoin, it would be worth and just publishing it because it will change the way we do medicine for many more people.
Thank you. Next question is, I think, to all of us about tranexamic acid. Does anybody have experience with that, Linda or Anna? I don't have. Okay, not for rosacea exactly. Pigmentation, yes, but not that. Okay, then next question about isotretinoin. Low-dose treatment with isotretinoin in papular rosacea. You meant on that, yes?
I have used low-dose isotretinoin for especially moderate to severe rosacea in the past. What's interesting is that with the newer treatment options, I very rarely do it anymore. And it's surprising. Sometimes I'll have a patient, and while I'm getting the paperwork ready, and I put them on one of the newer medications, often combination with an oral and a topical, and then they come back, I'm like, oh, well, you look great. So I do it, but it's just much less than I used to.
I agree, and it's also in some cases when it's recalcitrant to antibiotics or there are side effects or contraindications, then yes, it can have a good effect, but you need to do it long enough. I always tell the patient you need to take 4, 5, 6 months.
It might reduce the glands, sebaceous glands, that's why it works.
Okay, then Professor Anzenberger about rhinophyma again. Do you have success with isotretinoin for inflamed rhinophyma better than doxycycline or topical medicine?
Yes. So, okay, I understand when I look at the replies that I should answer a little bit more at length. I always feel that you can get it better with antibiotics, but as soon as you stop, you get a relapse quite fast. This is my experience. I feel with isotretinoin, it lasts longer.
Yeah, I think it's also important to have some kind of a maintenance therapy in a way. We often do that in atopic dermatitis, but in rosacea we often forget this, and I have quite good experience also with maintenance. Sometimes I have some patients once a week or twice a week on minocycline or isotretinoin, very low dosages, and the rosacea is controlled. How about your experience with these kind of low-dose maintenance therapies? Yeah, for example, with minocycline, doxycycline, or isotretinoin.
I tend to use now either one of the submicrobial dose doxycycline or the lower dose minocycline. Often, though, I don't use a systemic for the long-term maintenance. Sometimes it's just a topical. And although we don't have good data, often I'll go till clear and then use it maybe 2 or 3 times a week as maintenance therapy.
Okay. Let's see what we have. Okay, that's a good one. Any tips on managing Morbihan's disease?
All right, that is a very good question. Does anybody else want to? Okay, so if you look into the literature, basically you get the same as for rosacea. You get isotretinoin, you get doxycycline. We looked at it, we had biopsies of solid facial edema or morbus Morbihan patients, and we tried to find a cascade. We looked at the inflammatory profiles, and we tried, and that was 7, 8 years ago, we tried biological treatments, and they did not work. Yeah. So we thought, but we never published the story that maybe the JAK STAT pathway is involved. So today that might be an option to try to give it to a patient. But other than that, I still think it's a very difficult disease to treat.
Okay, we stay with rhinophyma. A lot of questions on that. There's a need for that. How about loop electrosurgery for rhinophyma?
I showed the picture when I showed the picture with the blade, the CO2 laser, and I think I briefly mentioned it. It is especially used when patients have more severe rhinophyma, because you can do it aesthetically very well. I don't use it, but I know a lot of colleagues use it quite successfully.
Okay, thank you. Then 2 questions for Linda about one from Australia. Question is, in Australia we only have Mirvazole. How long can you use it continuously due to rebound effect?
What's interesting is the rebound effect doesn't necessarily correlate with how long you use it. For some patients, you use it and you might get it the first time or the second time you apply it. So I'm not sure that that's going to make that much of a difference. What we do know is if you use another anti-inflammatory drug in combination with the brimonidine, it decreases the possibility of that rebound erythema. So we saw in the combination study when they used ivermectin at night and brimonidine in the morning, the rate of rebound erythema was really minimal.
Mm-hmm. Then another question for all of us is regarding how long should patients take doxycycline or minocycline for rosacea? So how long they usually reflare when stopped? So we can share our opinions on that, or our experience.
I don't mind starting. I will share with you that there are some of my friends and colleagues in the United States who are dermatologists who treat their own rosacea with submicrobial dose doxycycline, and they've been on it for many, 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 many years. And they do that because they think that it's decreasing systemic inflammation as well. They're not concerned about the potential for bacterial resistance because it's submicrobial dose doxy. So I don't have a fear when we're using a low dose that's been proven to be only anti-inflammatory. I don't have a concern about using it long term. Full dose antibiotics I would only use for up to maybe 4 months or so, and if I'm not getting them under control, I'll probably look for another option.
Maybe I can share my experience having rosacea clinic since more than 20 years, and I see about 20 patients per week. And my experience is over the years is that really it makes a difference when you use maintenance treatment with systemic. So I have some patients who use minocycline or doxycycline once a week. They are controlled, they stop it, it relapses. I go back and they stay on one tablet a week or 2 tablets a week, and it's individually very different, also depending on the severity and how long they had the rosacea. But definitely to my, of course not, it's more anecdotal to experience of 7,000–8,000 patients, but there is an anti-inflammatory effect when you use low-dose therapy, and I have some patients use it for a long time and don't want to stop it.
You study, I have different patients. They're always scared of using antibiotics. So I try usually to convince them to stay on it at least 3 months continuously, and then as soon as they get better, I increase with topical, and then I try to wean them out, and then repeat it when they flare up.
Yeah, that's a very important question. Okay, do you see any more? I don't have. Maybe one, just one last question.
May I ask you a question?
Somebody before.
Sorry for the...
Thank you so much for telling.
Well, I have a question about perioral or periorificial dermatitis. You know, there's an entity where we can see sometimes papulus pustulosus and demodex and the things that can overlap with rosacea. And there's a debate what kind of disease it is, especially related to use of topical steroids or something unrelated. So can you say something about this clinical entity of perioral or periorificial dermatitis?
I often treat it the same way I do rosacea, so I do feel there's somewhat of an overlap. Either with, so often I'll try topical ivermectin, I might try antibiotics. It can be very challenging, though, sometimes to get control of it.
Yeah, that's also my experience. And in addition, is that the glucocorticosteroids make it worse, and you have the rebound effect and worsening of the effect. So that would be the worst solution, and the best is, and also sometimes to really have some anti-irritation effect over a couple of days, and then to apply more the topical antibiotic or ivermectin.
Yeah, for me, the usual cycle that I see is seborrheic dermatitis treated with steroid, and then develop the perioral dermatitis. I've been lucky with doxy. Usually, I resolve the problem and I explain them why it comes. So they might be similar.
And if it's severe, sometimes even then systemic. Low-dose minocycline or low-dose doxycycline, better than glucocorticosteroids.
Thanks.
Okay. Any other questions from the audience? Then I think we had a wonderful meeting. Thank you so much to the speakers and to the audience. Thank you for staying so late. And see you. Enjoy the time.